Well, we're at 12:30, so I thought we'll start in a timely fashion. How unusual. Chris Comfort here. I'm a palliative care physician working at Calvary Hospital now, um, taking responsibility for both the hospital, the hospice, as well as our palliative care, both inpatient and community-based program. And I've been asked to moderate today for the virtual annual meeting of the Empire State Bioethics Consortium. And Zimmerman will give us a bit of an introduction to that. Our topic today, we are ambitiously looking at serious illness and dying as a meaningful experience, talking a little bit about the ethical considerations of equity, access to care, and choices in end-of-life care. We're doing a moderated panel. I'll give you the format of it. It's fairly easy to understand. We've got some wonderful members of our community who are going to give us some expert views on sociology, medicine, pastoral services, ethics, and the law related to end-of-life care. Rather than focusing on any ideal vision of end-of-life care, we prefer that the panel will explore a number of avenues to meaningful end-of-life, palliative care, hospice, and medical aid in dying, to connect the vision of where palliative services and hospice fit into our end of life, and to look a bit at the success of that over the past several years. We talk a little bit about access to those services. We talk a little bit about whether those services are trumped by either societal or institutional direction of care at end of life to hospital facilities. And we also want to touch on the important aspects of the pending medical aid in dying legislation in New York, talking a bit about the hurdles to access, potential for abuse of that, the risks to vulnerable populations, the impact of that issue on palliative and hospice programs, and a discussion a bit about the workforce training needs and redesign. Let me introduce you a bit to the panelists, and I'm going to let them talk a little bit about themselves, but I want to give my personal comments on the expertise and the breadth of variety of the people we have here today. Lauren Hall, who is Professor and Associate Dean of Academic Affairs at the Rochester Institute of Technology, is joining us. We look forward to her comments. She's in political science, and she's looked at the history of the structure of policies that commonly force individuals for care into hospitals rather than supporting access to services in the community. And I think we're all very interested in hearing about that. John Dow, who's assistant counsel at Trinity Health, is uniquely situated to talk to us in great detail about some of the structures and the financing of these kinds of services that are offered. I was particularly interested in and consider him really an expert in PACE programs throughout the United States. Here in New York, PACE has been programs that have been instituted both here in the city and throughout the state. But I think John represents probably the lion's share of knowledge, practically as well as structurally, for PACE programs as they are introduced here into New York State. Linda Golding, she is the coordinator of spiritual care and chaplaincy at NYP Columbia. And she's going to give us an opportunity to look into some of the issues that are dealt with from an ethical perspective at end of life, with a boots on the ground, giving care on a daily basis kind of perspective that I think will be both original and insightful in terms of its depth of understanding. Karen Bullock, who is from the Boston College School of Social Work, is with us today. She has studied extensively health disparities and, in fact, are going to be giving us a perspective that I think is expert in terms of the issues practically that are dealt with disparity, but also an understanding of how the systems that we've set up ourselves may have contributed to that disparity, not only for inpatient care, but community care as well. And then we have Susan Hedlund, who's with us virtually from Oregon. She's the Director of Patient and Family Services at the Knight Cancer Institute, part of the Oregon Health and Science University. She has lived the story of MAID during its introduction in Oregon, and I think is, among all of us, probably the one who has the most insightful information about the implementation of a MAID program, and talking a bit about the successes and failures of that as we move on to our discussion so far. That's our panel, and Anne, if you'd like to begin with a few words for us, then we'll move on into presentations.
I think we are ready to move right into the presentations. So Chris, why don't you take it back and go ahead, and we'll start with the first panelist. Thank you so much. And welcome, everyone.
We're going to try to have you out of here by 3:30. So we're going to go in a fairly timely fashion. I've warned everybody they got 7 to 10 minutes, but they're fine with that. So I think that'll actually work out pretty well for us as we go ahead. Just to mention, there are some breakout sessions that will follow these presentations, and the breakout sessions really do help us to understand a bit about the discussions that the expert panelists will give for us, and then give you an opportunity to interact with them to see if we can have a truly conversational discussion about things so that it is helpful for all of us. I'm going to be monitoring the chat, and so if you've got particular questions, please feel free to introduce those questions into chat, and I will be at the end of presentations helping out us a little bit in terms of directing our speakers and our panelists to be able to give you a little bit of a hint of what is coming in the breakout sessions by directing some questions to them. I was going to start this out, and I think the way to start this out is to say I think it's helpful to look at a bit of history of palliative care in understanding how it came about and its introduction throughout the United States. And I'm going to pay particular attention to the development of palliative care here in New York, and in particular New York City, because each of the geographic areas of the United States has had a different way that palliative care has been introduced. But I think it's fairly universal that palliative care is recognized as a relatively new subspecialty in medicine, or specialty in medicine. And I think there are those of us who participate in that who have lived that history of truly an inpatient consultative service. This is a institution that's present for about 20 years, maybe 25 years. Many of the initial founders of this movement had very interesting experiences. Let me give you an example. One was Joanne Lynn, who has done work in palliative care really for years and years, and she began her career as a researcher and did, in fact, was lead author and did the support study, fascinating study, taking 5 university centers, 3 of the 5 academic, and had an interesting question to ask. What happened when you took a team that was focused on patient and family-centered care, whose role was to help with symptom control and to clarify decisions related to preferences of care, and compare to see whether that kind of a team made a difference in the care of patients? This was about 1998 when it was published, and fascinating results came out of that study. When you looked at the idea of the question of physicians knowing what the preferences of care for patients were for specific issues, even something as simple as do not resuscitate, she found that 50% of the time the physician was correct in his understanding of what the patient preferred. 50% of the time he had no idea what the patient wanted, or in fact was wrong in terms of his understanding of what patients wanted. When you looked at the identification of care teams outside of a palliative team, understanding preferences of care, 20 to 25% of care teams were correct in their understanding of the care that the patient wanted. When you looked at control of symptomatology, it was fascinating to look at statistics related to how patients with palliative conditions in their last year of life actually live, with hospitalizations for issues indicating that nearly 80% of patients admitted to hospital related to a late stage illness had severe pain as a complication of their illness. And that often was not identified appropriately by care teams if there was not intervention with a palliative group. In addition, it noted that this was not related to exclusively cancer diagnoses, where cancer and non-cancer patients were reporting pain at fairly the same frequency reported in that study. Fascinating to this study was the fact that it actually ended up being a null study, which means that Joanne could show no improvement in care, in fact, no difference in care between usual and customary care and the addition of a palliative team in terms of this interventional study. Interesting that a whole subspecialty started out of a null study in terms of efficacy and interventional benefit. But what happened is that the concept of identifying preferences of care and advocates for patient and family related to symptom control became quite popular. At this point in time, the vast majority of hospitals within the United States do have palliative care programs, but the majority of those are in fact dedicated to and centered in the hospital itself. Fascinating that the idea of community-based services is something that took several years to develop in terms of the concept of palliation and the providing of palliative care through institutions and then into community groups. Movement into the community by palliative care was really spearheaded not by institutions where the palliative care programs existed, but was actually initially spearheaded by hospices. So hospices doing business in the community actually were able to expand their services into palliative services, and they piggybacked basically personnel who were involved in taking care of hospice patients and the team that is associated with the care of hospice patients into the care of those patients who either did not make criteria for hospice, typically based on either the certificate of terminal illness not documenting a 6-month survival, or patients who actually did not have discrete diagnoses that would be recognized easily by hospice to justify the stay in the program. And the second group that they ministered to were those patients who decided that they did not want to opt into the hospice program. Hospice is a fascinating subject. Hospices are clinical entities. They take care of patients, but hospice is also a payment source. And so it's a program that's supported by the federal government where the patient literally opts out of their traditional Medicare insurance payment process and moves on to a completely different reimbursement program. So there are impediments for patients accessing the hospice benefit related to their feelings about moving out of the traditional medical system, as well as a stigma of hospice, which clearly identifies late-stage disease, has a patient understand that the prognosis of less than 6 months has been indicated by their attending physician. So there are many patients who prefer or choose not to elect hospice as a benefit because of these impediments. In addition, programs that were community-based palliative programs also started to develop as bricks and mortar programs. And if you look at palliative care programs from most institutions, those institutions run palliative care programs that are actually clinic programs. They sit aside heart failure clinics, they sit aside or embedded into oncology clinics, but rather than being resources that move into the community, they are resources that are available at hospital settings or clinic settings with the inconvenience of patients having to come to the doctor or to the practitioner rather than the practitioner and the team moving to the patient in their own home, such as in the hospice model. And then recently, there have been the development of palliative community-based programs who center their care in the community itself, making the place of care for the patient and for the family in the confines and the security of the patient's and family's home. That model has been difficult to institute because of two variables. One is that it's an inherently inefficient method. So house calls in the old days and community-based practice at patients' homes is not the efficient model of either hospital care or clinic care. And secondly, most of the reimbursement for these programs in the United States, save about 14 states that have specific reimbursement related to palliative care programs, still remains a fee-for-service physician or practitioner-based program. Those states who do not support palliative programs with additional reimbursement for patient election are going to need to look at that model over the next several years, because the ability for palliative programs to move into community and to service patients within the confines of their home are going to be dependent upon an economic program which allows these programs to be sustainable. When you look at most programs, whether they end up in the clinic setting, in the home setting supported by hospice, or independently in the home, are, from the economic perspective, programs that, unless they are involved in value-based arrangements, money losers for the organizations who support those programs, and will remain money losers until there's an understanding of an equitable way for the payment of those resources. So I hope that gives you a bit of a history to palliative care and an understanding of where in the community or outside the community those services are offered, a tidbit about what those services look like, and then a comment related to the affordability of those programs related to the current payment system. I don't think my conversation is the important one today, but I did want to start us out with a foundation and see where we go from there in terms of where this takes us. What we're going to move to now is a discussion from Lauren Hall from the Rochester Institute of Technology, to talk a little bit about the structure of policies that support care either in the hospital or in the community-based setting. She has a tremendous amount of research experience related to this, and I'm very, very excited to hear what she has to say. Lauren.
Thank you so much, Chris. Thanks. It's wonderful to be here. I hope everyone can hear me okay. Hopefully you can drop into the chat if you're having any issues. What I hope to do is provide a very high level, and I mean very high level, view of the major policies. And so the metaphor that I use in other work is to think about this as a watershed. So imagine that you have this landscape and you have these sort of mountains, and the structure of the mountains affect what happens downstream. And so this watershed of policies affect the way that people navigate the river of end-of-life care. So I'm going to argue a couple things as we sort of move through the next 7 to 10 minutes. The first is that there's this broad structure, and a lot of this has to do with the history of the way that a lot of these policies were sort of litigated and created, and the people who were in the room during the creation of these policies, but also the way that those policies have really, really crucial and serious ethical implications for both patients and providers at the end of life. So we'll kick right off with, and we're going to cover again about 100 years of policy in 7 to 10 minutes. So the first one we're going to start with, it goes back further than this, but the first one we're going to start with is the Hill-Burton Act of 1946. And I'm going to start with federal policies and then narrow into state policies, and you'll see sort of why that makes sense sort of at the end. So the Hill-Burton Act, a lot of these acts, almost all of these policies had really laudable intentions. So the goal of the Hill-Burton Act was to get people back to work after coming back from the war. So it was kind of a jobs policy, but it was also an infrastructure boost. And the goal was to provide hospitals to communities, particularly rural communities. So to sort of serve as a job creator and an infrastructure bill. What ended up happening, though, is that you created this sort of glut of very expensive, centralized medical infrastructure that then you had to use. And so we kind of created this framework for where medicine happened that was much more centralized. As Chris mentioned, this move away from the sort of physicians coming to your home. Right now, the expectation is that patients are funneled into the hospital environment. And so it also led to, because of the structure of the bill itself, there was an expectation that the number of hospitals should grow as the population grew, as opposed to thinking about other kinds of models that might come up along the way, decentralized models, community clinics. And so we oversupplied hospitals. We essentially created this expensive infrastructure that became too big to fail. And so some of the implications of the end of life of the Hill-Burton Act are that they serve as kind of a magnet that prioritized hospital-based care over traditional kinds of community-based care, like doctor-physician visits or hospice or visiting nurse services. So that's 1946. The situation is compounded with the Medicare Act of 1965. So the goal of Medicare was, again, really laudable. The goal was to provide affordable healthcare for seniors as their healthcare needs grew, and as the technological capacity that we had to treat people grew. It became really necessary for the government to step in and to provide some resources for the growing senior population. The result, though, was in part because we had a really heavy influence by physicians and hospitals. So the American Hospital Association and the American Medical Association were really crucial in deciding the structure of Medicare. They were very concerned about autonomy and state control of medicine. And so the result was a really heavy focus on physician and hospital needs, and a focus on reimbursing procedures. And so what this means is that in our major bill that talks about reimbursing care for senior citizens, we neglected completely high quality and iterative communication about goals of care. There was no reimbursement for the kinds of those kinds of conversations. And the policies ended up distorting the market and really kind of limiting innovation, because they funneled resources into hospital and physician-based care, leaving things like, for example, hospice and nursing care and home health care really under-resourced. So one attempt to fix that comes in 1982 with the Medicare hospice benefit. And so the goal here was to provide support for hospice at the end of life. Now, I mean, again, this is an interesting one, because we think that the Medicare hospice benefit, and it did provide this really wonderful access to hospice, but it's interesting to note that Cicely Saunders had serious concerns about the structure of the Medicare hospice benefit, in part because she was deeply concerned about the standardization that the hospice benefit, and particularly the way that it was structured, including requiring patients to give up curative treatment and requiring a 6-month prognosis, the way that standardization would interfere with the traditional goals of hospice. And it turns out that her concerns were, in fact, somewhat realized. Part of the result of the Medicare hospice benefit was standardized care at the end of life. We actually standardized the reimbursement structure around the experiences of cancer and AIDS patients, as opposed to thinking more broadly about the needs of a wider variety of patients, including dementia patients, which is a growing population right now whose needs really can't be met on the current model. And so we have, again, this kind of increased standardization, prioritization of hospitalization and procedures. And because of the flat rate that the Medicare hospice benefit creates, it makes it really difficult for more complex patients to fit into that standardized hospice model. So shifting over to the state side, there's two major state policies that interact with these Medicare policies and with the Hill-Burton Act in important kinds of ways. And I'll just mention them quickly. The first is certificate of need laws. And so we have those in New York State. Not every state has them, but they're relevant for the New York context. The original goal was to limit costly competition by ensuring that really expensive new infrastructure is actually needed. What actually ended up happening is that certificate of need laws actually allow hospitals to limit competition. And so what happens, for example, in the New York context, and this is also in the case of Florida, is that the certificate of need process is so expensive to get through that it actually privileges entrenched players, and it actually encourages corporatization. And so one of the major sort of at least anecdotal arguments for why Florida has such a huge proportion of corporate hospice players is because the regulatory compliance costs of getting through the certificate of need process and then the additional regulatory costs are so great that only corporate hospices are able to get through that hoop. And so that's a real concern about, again, distorting the market and really changing the character of hospice as a decentralized and destandardized and very personalized form of care. So the last law that I'm going to mention is licensing and scope of practice laws. We're all familiar, I think, in this group with the way that licensing has impacts on the way that, for example, at the end of life, nurse practitioners can't certify terminal illness, which often delays entry, right? There's a range of sort of licensing limitations, and a lot of these come back to the physician-centric way that Medicare was originally created. And licensure goes back much further than Medicare, but this is another piece of that puzzle. By sort of creating this very physician and hospital-centric model, we've crowded out other kinds of caregivers and providers who could actually be more flexible and could provide more care in the home. I'll mention very, very briefly, too, that opioid restrictions have also had obviously really, really serious impacts on particularly the hospital context. So I'm just going to end very quickly with a couple important ethical implications. One of the things that I think we end up with is that standardization of acute treatment in both hospitals and with physicians creates these kinds of treatment funnels that we can't get out of. So there's protocols to escalate care in hospitals, but there very often are not protocols to de-escalate care. And that means that both providers and patients get stuck with this really high level acute care. I think Karen's going to talk more about this, but standardization also ends up threatening those whose goals and values differ from the norm. So minoritized groups, those who would like less acute care, or those with different religious beliefs, for example, are not going to fit really well into a standardized, centralized kind of end-of-life care. And they're going to have a really hard time getting their needs met in a system that really de-emphasizes high-quality, iterative communication. If we don't have that, they're going to have a really hard time being heard. And then the other piece of this is that the focus on acute care instead of this iterative communication really seriously threatens informed consent. And so overall, I think the standardization and centralization of this broad policy watershed really threatens providers' ability to offer the kind of care that they know dying people need, and also threatens the ability of patients to have their needs and preferences respected at the end of life.
Wonderful, wonderful, Lauren. Thank you. Actually, Dean Hart has a question that you may be able to help us with, but see if you can handle it from your perspective rather than having to do a clinical perspective. It's a question about the difficulties in the care of dementia patients. You mentioned yourself that the hospice model doesn't fit dementia very well based on trajectory of disease and also care needs. But he is also saying the idea of the role of palliation in dementia. So from your perspective of structure, can you talk to us a little bit about the idea of dementia, the warehousing of individuals in bricks and mortar facilities known as nursing homes, standard, not specialized care related to memory disorder, and where you think all of that grew up?
Yeah, so I can't speak too much of it to this in terms of the policy perspective, because I think dementia is one of those areas that we do not have good policy solutions for. It's typically very costly. You need to have very high levels of supervision for dementia patients, which means they don't fit well into the typical hospice model, where you have people who are otherwise capable of making decisions for themselves, but need a certain amount of care per day. I do think that we really need to, so one of the things I'll mention very quickly, and then I do want to make sure that we have time for the other speakers, there's a lot of conflicts within the structure of Medicare itself in terms of the reimbursement rates, for example, for hospitals. There's incentives for hospitals to punt more complex, for example, dementia patients to skilled nursing facilities, but then those skilled nursing facilities get a higher rate of reimbursement for the first 100 days of care. And so there's actually an incentive to cycle them in and out. And so we get this revolving door of care that, it's not even that we don't have a good place for dementia patients to go, but we actually create incentives for institutions to cycle them through hospitalization, skilled nursing facilities, and nursing homes over and over again, which we know dramatically increases the rate of medical error, increases the rate of falls and other kinds of harm. So I think we have a real structural problem.
Yeah, it's interesting if you look at hospices doing work in nursing homes. Um, Probably about 80% of the diagnoses that they have on service are actually dementia or related diagnoses to dementia. If you look at the length of stays of those patients on hospice, they are 3 to 4 times the length of stays of their community-based patients that they have. And Dean had also talked about underreporting. One of the very common diagnoses for hospice, in addition, is this, which the feds hate, failure to thrive diagnoses, which in fact you'll see very, very commonly a lack of an evaluation for a diagnosis of dementia. So not only is there underreporting of dementia related to death certificates, there is a dearth of evidence that the identification of dementia as either a coinciding diagnosis or the primary diagnosis is lacking as well. So Dean also asked about the redefinition of palliation, and I think I'm going to let all of us think about that, because that will be something I think we'll get to as we go ahead. Next up, we have John Dow, who's from Trinity Health. And again, I was particularly impressed with his breadth of experience in care systems, including PACE. And he really is a great resource for us to understand the structure of those programs and the economic implications for those programs. So, John, the stage is yours.
Thank you for that introduction. I just have to say I'm really humbled to be amongst this panel. I guess I'll start perhaps with a guiding thought that's going to build on the wonderful foundation that has been set for us. And I don't know if it's something that we'll be able to answer before the afternoon is over, but I guess I'd ask a few guiding questions, and that is, do we have both a negative right to good aging or a good death without interference, and a positive right to have that covered by insurance, public or private? And further, is it even possible to come up with a vision for that kind of end of life that embraces therapeutic choice, third-party payment, but balances the policy aim of controlled expenditure? I think my colleagues have done a very good job of pointing out that the system is currently focused around the hospital. And if anyone has seen the show Scrubs from back in the day, there's an image in that show where they turn the hospital into this monster with a big mouth that's opening and closing. And it's, in that instance, they're talking about time consumption of residents. But I would say that it is also, for all the reasons we've just discussed, a system that has to be fed to sustain it. And, we in hospital administration, we see that. And we understand, though, that it is not what our patients necessarily want or need, but it's difficult and expensive to move away from that model. That system came about through a history of choices and compromises, as we've just heard. But I think for the purposes of our discussion today, I'll take a slightly different approach to reviewing the history, I guess, of a right to die, or what a good death looks like. I think that history of discourse in the US goes back to at least the 1880s, but I would say it kicks off again in the 1980s, and then comes to really a more of the pace we see today with an article called "It's Over, Debbie" in the late 80s to early 90s. Then we see some of the legislation in California, Pain Relief Promotion Act in the late 90s, and that really leads us up to today. And all of those discussions, I think, center around this idea from both an economic and a policy perspective that, on the one hand, the state has a compelling policy interest to maintain a certain amount of regulatory control, to maintain a certain amount of control over expenditures, but that's hard to, I guess, balance against ideas of coercion, of a doctor's role to guide care, or perhaps to overstep in a sense and truly decide what should or shouldn't be, rather than merely act as a guide. When do those things become contrary to the doctor's role as a healer. And of course, a systemic, I think, need to standardize. I would counter and say the tide for me starts to turn in 1997. I'm looking at the Quill case, particularly Stevens's concurrence. In my opinion, that's where we start to see the door open, where there's a balance that's acknowledged that we have all those concerns, but perhaps there is also this openness to exceptions to that rule, that we can create that policy flexibility where people can make different choices in some cases. All of these discussions, ethics and law are totally intertwined. And if you heard perhaps a more ethic than law tinge in a lot of what I was just saying, then you're right. The way that we as lawyers, I think, try to think about how law, policy, economics bleeds into that space is to balance, I would say, vitalism with perhaps mere reverence or respect. And I don't say mere to discount it, but we as advisors, and ultimately that's what lawyers do, are trying to help our clients navigate a highly regulated space, but in this case also maintain that respect for the incalculable intrinsic value that human life has, that has to be balanced against business interests. So, as we've kind of talked about a little bit, the landscape is changing, and we'll talk a little bit more about payment for those services in a minute. But I'd be remiss, I guess, if I didn't talk about the intrusion, and it is an intrusion of for-profit entities in the hospice space. 7 out of 10 hospices, at least in the US, are for-profit, so this is a big business. Though those acquisitions are often small and fragmented, let's get real, those deals add up. And it's a trend that's hard for regulators to spot or monitor. Hospice is a great space for private equity to enter. There's low barriers to entry. It's comparatively unregulated, unmonitored, as opposed to, let's say, a hospital or a surgical center. The payments are, as Lauren just kind of mentioned, something that can be gamed. And I guess, where does that get us? Well, to try to move things along as quickly as possible, I'd suggest you all go look at the Milliman study, which came out in 2019. You can find that online on your own. Now, before I get into what it says, whether or not you trust a lawyer to talk about math or not, I'll let you draw your own conclusions. But one of the issues with the study, before we talk about its findings and perhaps what that says about the industry, the study had a low R value, which means that the correlation between the variables they looked at was positive, but not very high. So whether or not it is predictive in all cases is questionable. But the underscore in bold point that they essentially made is that not-for-profit hospices have lower margins than for-profits. However, they are providing more nursing visits, more social worker visits, more therapy visits versus a for-profit hospice per day. Nonprofit hospices are the ones taking on patients who have usually higher hospice and hospital needs. So they're high acuity patients that they're going for. And they're typically spending, for-profits, a great deal of time and money on competing. So there's a very real interest in coming into this space. So ultimately, what this all gets down to is the idea that there's a great deal of money at play. There's a great deal of interest in moving in the palliative and hospice care space. And I think particularly as we think about changing that landscape with the potential introduction of medical aid in dying in New York, we do have to think about how we support everyone in providing high quality, affordable, accessible care. Now, we all know that the Palliative Care Access Act and the Palliative Care Information Act have been law in New York for quite some time. But I think if you speak with physicians and with social workers and all members of the allied health team, you'll find that one of the greatest needs that they'll express time and time again is a need for funding that doesn't merely cover the interaction with the patient, but that supports their ability to understand how to have those interactions, when to have and recognize those interactions, and that supports that tie-in between whoever the patient may be seeing and their palliative care partner to be. So I would say it really can't be lost, and we hear, I think, about how other states who have, for example, medical aid in dying, did not do so with an appropriation attached. I would not suggest that we necessarily need to do that in New York, but along the way we have to build these systems, because what many other states have experienced is, as medical aid in dying became law, there was a greater use, and this is a good thing, of palliative care and hospice. So how do we attack this without spending public monies? Well, I think we have to recognize that the state legislature has a great deal of power to influence, if nothing else, how insurance payers work in this state. While they may not be able to influence all payers, the legislature has proven in past instances that they have the know-how to specify the richness and the details of an insurer's network, or the coverages that must exist within a product. So for those types of insurers, I think the legislature does need to touch who they can touch. And I would refer all of you perhaps to S1196 from 2023 or S659 from 2019. These are both bills that can be models for how we do that. I guess just to try to be mindful of time, another probably overlooked aspect of this, beyond training, beyond paying for care, is the language that we use around medical aid in dying. It is a specialty that is in its infancy, and I do think that we need to make sure that we are frequently thinking about, are we developing good protocols? Are we using language that facilitates off-label uses of both the drugs involved in medical aid in dying, and in those that may complement it from a palliation or a hospice care perspective. And beyond all of that, we have to, I guess, keep that reverence idea in mind. These are individuals, meaning patients, who are dealing with extremely difficult life choices, existential questions. They need to be aware of their options, and we have to, I think, keep that at the core of whatever we do. There's a lot more to dig in, but I'm sure your questions will tease that out. So we'll leave a little more time for that.
Very, very helpful, John. Can you say a few words about some of the value-based and demonstration kinds of projects that you've been involved with, and in particular, for example, a comprehensive program such as PACE?
Sure.
And talk a little bit about the benefits of that, but also talk a little bit about some of the economic influences based on that payment model that may limit the kinds of interventions that a traditional PACE program would be willing to give.
Sure. So I would say that, one of the things we struggle with is that I don't think CMS has fully embraced the value of programs such as PACE, or such as really community-based programs, though they have certainly done pilot programs, as you mentioned. I would refer people to the MCMM model, for example, which is a recent example of a model that could give folks the kinds of choices that I think we desire to give them as healthcare providers. That's really probably the major barrier. The other difficulty, in my opinion, PACE being a hybrid. So for those who may not know, it's probably the minority of you, but PACE is a combination of Medicaid benefits, such as long-term care, and Medicare into one program. And the flexibility that it provides is that it adds things such as dental care, eye care, things that are perhaps less utilized. There are certain ways to create housing benefits around moving expenses or other life changes that allow you to really embrace the patient as a whole. But to do all of those things, it requires a considerable amount of institutional expertise. And quite frankly, that's just not necessarily going to exist everywhere. A number of other panelists, I think, are going to talk about their experiences with community services in other areas. So I don't want to step on their space. But I guess it's, in a sense, the difficulty with PACE is that lack of embrace by many payers and regulators, the acquisition cost, in a sense, to try to build out the program and maintain it and fully understand it. And with that, there's an underlying difficulty where regulators, I think, struggle with managing the payment model and with providing appropriate guidance and guidelines as to what it should really look like. For all of the reasons we've just discussed, it is something that is a shift to where I think we were in medicine and in holistic care, but is just not essentially what, for several generations we've built knowledge around.
I think just lastly, John, just your personal feeling on this. Do you think that it is possible to design an appropriate late-stage disease care system, not medical system, but care system in those who do not have, who are not duly eligible? In other words, what's the impact of Medicaid in really running support programs for the elderly? And are we really talking about needing to understand that our current methods of doing it with the divisions of insurances just don't promote those kinds of programs to be successful?
Sure. Well, let's take all the techniques out of the equation for just a moment and think about this as a patient. I think that almost answers the question for you. All of us have probably had loved ones who were going through a period of time, through their aging process, through their end of life, who looked to us for some advice and some expertise. I think, speaking as a lawyer, it probably started for me with the first person who wanted a traffic ticket handled, and it all just goes from there. But again, I think it answers your question in that when we have a system that is so siloed, and ultimately that is what these products create, are silos of benefits, unless that patient is either part of a system that has all of those tools at their disposal, or unless they have access to knowledge to help them navigate it. I think before you even think about this from an economic or a management perspective, leaving it just at a, is it something a person can navigate? The answer really has, in part, to be no. The current system started with good intentions, but in trying to treat it as something where we have to tweak and waive and adjust, has become really like trying, frequently to put a square peg into a round hole. You have to find the silo where someone sits. So from a person-centered perspective, I think the answer has to be no. From a regulatory perspective or a management perspective, I'm more hopeful. But I started speaking, I think, from the point of reverence, and I do think, again, to take the management perspective hat off for a moment, that my answer really does have to be no. I don't have the answer for what comes next, but I can tell you that what we're doing now is just probably not cutting it.
All right, John, thank you so much. I think you can see the theme here as it migrates into accessibility to care, to impediments to delivery of the care, and the idea of some of the dynamics that lead to differences in care or disparities in care. And so Karen Bullock, who is from Boston College Social Work, who has done a tremendous amount of work related to this access of care in the community, related to either disparities of care or access to care. Karen, I'd love for you to share us your thoughts moving forward.
Laura, thank you very much, Dr. Comfort. And I also want to thank Lauren for setting up this opportunity for me to segue into my presentation, because much of what you talked about, Lauren, in terms of the policies that were enacted, influence what I was going to talk about. So I'm going to reposition and start at a kind of a different place. I want to recenter medical aid and dying and the discussion. And just for those who may be in the audience to think about this as I forge ahead, talking about racial and ethnic disparities and the historical context. So medical aid in dying has been characterized as an increasingly supported end-of-life option that provides dying people with a peace of mind and comfort during the most difficult times. I think we can all agree when we're faced with incurable illnesses. And although a small number of people will choose this as an option, having discussions about the availability of medical aid in dying is supposed to bring this comfort to patients and help them to feel better about the options. However, when you are a member of a group or a community or a population in which there have been huge disparities, it can be very challenging to think about an option like medical aid in dying as being available to you and centering your values. And so I think it's important for us to think about the broad sort of range of patients and patient experiences when we are embarking upon the medical aid in dying as an option that most people, if not all, can see as an option for them. And so as Lauren talked about the historical context of the Hill-Burton Act and in 1946, all the changes that were sort of ushered in, these changes were not intending to impact the quality of life nor the quality of health for Black patients. And so for older Black Americans who have lived through legal racialized segregation, healthcare systems to date still don't provide what many people believe to be equitable care. So although there were large policies that were ushering in these changes, and the reference to the Medicare Act of 1965, although President Truman, I'm sure, was well-intended with these acts, President Lyndon B. Johnson focused on both Medicare and Medicaid and the dismantling, if you will, of structural racism. So in 1965, President Johnson enacted desegregation, but for many health and hospital systems, they didn't comply until well into the 70s. And that's very recent. So if we think about structural racism in healthcare systems that was legal, and think about as late as the 1970s, there were still hospitals that were not opening their doors to Black Americans, then we can sort of contextualize, if you will, the legacy of racism, which continues to have a negative impact on a sizable population, US population, that tends to have higher rates of morbidity and higher rates of mortality. And so when we think about hospice, palliative care, and even medical aid in dying, we have sizable populations that aren't taking advantage of, if we want to frame it that way, or don't have access to what many of us consider the gold standard of care. And so to contextualize this, again, for many older Black Americans in particular, there is a tendency to have an aversion to healthcare systems that have historically denied them access to healthcare. So again, if we're going to think about ways that we can close some of the gaps that have existed since the beginning of time, as we've gotten the historical view of hospice and palliative care, and hospice care preceding palliative care. But if we look at the data, whether we're looking at CMS data or we're looking at NHPCO, National Hospice and Palliative Care data, we know that there are significant gaps. It's anywhere between 80 to 85% of the people who take advantage of or benefit from hospice and palliative care are white. That's wonderful for white people. But what do we do for older Black Americans who still aren't on board with this idea that hospice and palliative care is going to create a greater experience for them or more optimal care until the end of life? Perhaps in our discussion today, this afternoon, there'll be some discussions about how medical aid in dying might help to do that. I'm not sure. I can say that with the populations that I work with the most, which tends to be older Black Americans, and I use the term Black Americans rather than Black people, because not all Black people are African American. I think we need to think about the cultural context, because there are many Black people whose experiences have not been the same with the healthcare system in terms of interacting with or experiencing legalized segregation. So if we look at what was emerging in 1965 and look as late as 1970, for Black people who may have migrated to the US as late as the 1960s or in the 70s or even in contemporary times, they are not interfacing with a legalized healthcare system in the way that older Black Americans did. And so if we think about how that experience of legalized racial segregation influences the way in which older adults in contemporary times are experiencing healthcare systems, are considering, if you will, these more proactive ways of thinking about a great, wonderful quality of life. And in our discussions, how often are we centering race? Many of my colleagues, I don't think about race, I'm colorblind, race doesn't matter to me, I treat all my patients the same. What really are we saying when we say we treat all of our patients the same? I think we can agree not all patients need the same things. Are these missed opportunities for us to focus more on a cultural competence framework? To what degree do we know and understand the historical experiences of our patients and families before we begin to talk about these options and how great the access is for all patients? I mean, we generally talk about all patients, but when we refer to all patients, are we really referring to all white patients, or are we referring to all patients? And so we should be mindful about these quote unquote gold standards of care, how they have emerged, for whom they have emerged, and whether we're trying to retrofit some of our approaches to caring for people without having any level of competence. And by competence, I mean awareness, knowledge, skills that focus on goal concordant, patient-centered care. And so we, in real time, I suppose, don't have enough time in the day to meet our patients where they are and spend as much time engaged in conversations as perhaps we need to in order to understand the cultural nuances, to understand what would we need to do if we were going to have a model of care that actually centered a patient's cultural preferences. Now, in general terms, we say that is what we do when we're having conversations about goals of care, when we're engaged in conversations around advanced care planning. But if we really think about the frameworks and the models that we use, it centers whiteness and white culture. Again, that is wonderful for white patients. But how do we shift the framework? How do we acquire tools that enable us to move beyond cultural humility? Cultural humility is essential. However, cultural humility is not action-oriented. What are the kinds of practice behaviors that we need to engage in order to close some of these gaps? I often talk with colleagues who will say to me that they believe that cultural humility is the gold standard. The most they can expect to be is culturally humble. And the way in which I'm learning from my colleagues that they can demonstrate or engage in cultural humility is to be open, to be curious, to ask questions of the patients and families. But I think we can all agree that when someone is experiencing and managing a serious illness or perhaps even facing end of life, that is not the time to ask them to educate us, to teach us how to care for them. It is also not the time to disclose to our patients and families that I'm curious about you. I mean, if you're providing care for patients, shouldn't we already have a level of knowledge, awareness, and skills that enable us to have, if you will, a baseline for how we might approach care for diverse populations? None of us can teach what we don't know. And so I would argue that it's essential and critical that we gain skills and knowledge to think about what it is we can do different to ensure that we are meeting our patients and families where they are. So as we think about medical aid and dying, and we contextualize it as we're doing today, and think about Black Americans who have been denied access in US healthcare systems for much of their lives, and what happened in those US healthcare and hospital settings when the desegregation of hospitals was forced. And I say forced because it's not as though the hospitals were saying, oh, we knew we had it wrong, welcome, let's make these changes. President Lyndon B. Johnson essentially required hospitals to be open to Black patients. And we don't know very much about what happened within the US healthcare systems to prepare clinicians, practitioners, administrators, policymakers to think about what needed to happen differently in order to create a welcoming environment, an inclusive environment. And it doesn't happen by just waving a magic wand. It doesn't happen by just saying, I treat all my patients the same. One of the tools that can enable us to be more effective at closing the gaps, the structural racialized gaps in healthcare systems, is to think about actionable ways in which we can bring what many people say is unconscious bias to the forefront, to make it very conscious so that we can begin to deconstruct some of the frameworks and models that we're currently operating within. And think about cultural competence as awareness, skills, and knowledge that is transferable, not that it's a journey. It's not that it's a destination, it's a journey. We're continuously learning about how to improve care. Medical aid in dying is one of those examples of ways that it's believed that we can improve care. But again, my contribution to this discussion is to ask those of you in the audience and on the panel to think about the historical experiences of Black patients who have spent their entire lives in this country, who are still seeking care in these US healthcare systems. There are still people old enough to remember when they were denied access to care in US hospital systems. And we are caring for those individuals and those families in our healthcare settings. And so I think that it's important for us to think about cultural competence as a tool that might enable us to create a new normal in terms of the ways in which we care for diverse patient populations and families. And I'll stop there.
Thank you, Karen. I think those of you who are interested, because there's some comments here in the chat, those of you who are interested, please, to her breakout session, because I think she's hitting upon some fundamental issues within the medical system itself. I'll tell you, the federal government right now is looking at denials related to managed Medicare plans that clearly show racial bias. And they've got the Office of Civil Rights involved in terms of complaints. Even with the discussion of whether or not late-stage disease or end of life happens to be a disability or a protected class. So lots to think about in terms of that. And Karen, we thank you for your words. We're going to move on to Susan Hedlund. Susan provides a basic kind of interactive care at the Knight Cancer Institute in Oregon. And it has what I consider an impossible job dealing with both patients, but mostly their families as they navigate probably the most difficult time they're ever going to navigate. But Susan's one who has some experience with medical aid in dying and actually has watched its history in Oregon. And I think I think we all are in for some insightful words about the practical messages to us about where we are in New York and the decisions that we're making. Karen. So Susan?
Thank you, Dr. Comfort. I'm going to echo what John said. It is such an honor to be here with all of you. And I'm finding myself wanting to go to all of your breakout sessions or to just sit down and have long conversations with each of you. This is just a wonderfully enlightening panel. So thank you so much. As Dr. Comfort said, I'm a licensed clinical social worker. I have been an oncology social worker for decades, and all of my practice has been in the state of Oregon. Although I'm not a native Oregonian, I'm from Los Angeles, actually, which immediately has made me suspect to all of my native Oregonian friends. But I'm here to talk today about Oregon's experience with medical aid in dying. As most of you are aware, we were the first state to legalize medical aid in dying through a citizens ballot initiative. I think that's a really important point to bring up that it was driven by a citizen ballot initiative that was narrowly passed by a 2% margin back in 1994. It was immediately held up in the courts. There were, I think, 9 legal challenges to the act. And that actually was important because it slowed down the implementation of medical aid in dying. And my involvement was that I was one of 20 people tapped to be on the task force to improve the care of terminally ill Oregonians. And we were tasked with writing the guidelines for medical aid in dying. It was a fascinating experience. All of us were representing professional organizations or health systems. The task force was convened by 3 centers for ethics in our local health systems. And we were challenged to park our personal opinions at the door in terms of the ballot initiative and rather develop the guidelines. For me, in the course of my career, if I've been challenged to learn something new, I usually reach out to colleagues who have been there before me. And we didn't have anyone to call. A number of our task force members went to the Netherlands and studied their experience with youth, but that was not very immediately transferable either culturally or legally to what we were facing. We convened, we had representatives from the Oregon State Bar Association, the Oregon Hospice Association, the Board of Medical Examiners, the Board of Psychologists. I represented both the Association of Oncology Social Work and the National Association of Social Work. We had people from the Board of Pharmacy, ethicists, and again, representatives of all of our health systems in the Portland metropolitan area. I think it's important to also mention that Oregon is primarily a rural state. We only have 1 academic medical center, which is where I work at Oregon Health and Sciences University. And we are not a diverse state. We are becoming more so, but we have primarily been very white. We are becoming more diverse, specifically with a greater citizens that are either Latino or Southeast Asian. We do have 5 Native American tribes within about an hour's driving distance of Portland. But I think it's really important when you think about medical aid and dying and our history with it to recognize the demographics of our state, which are not immediately transferable to other states. What happened in those in that time that the task force was meeting was we developed the guidelines, were implemented in terms of how people could pursue medical aid in dying. The legal patient requirements are that the person must be 18 years of age. The person must be considered capable or able to make and communicate healthcare decisions. There must be a designation of a terminal illness with 6 months or less to live. The request must be voluntary. And the prescription requirement initially as written was 1 written request with 2 witnesses, 2 verbal requests, and a 15-day waiting period. And again, the confirmation of a diagnosis or prognosis of terminal illness, and that the patient must be informed of their other alternatives such as hospice and palliative care. What happened was that since the law was enacted, we've dropped the residency requirement, and we've also dropped the 15-day waiting period if death is expected to occur within 15 days. After the series of court negotiations, the ballot initiative went back to the voters in 1997, and this time was passed by a 20% margin. And there was a lot of thought that it wasn't so much because suddenly everybody was in favor of medical aid in dying that it passed by such a broader percentage, but rather that Oregonians are considered kind of libertarians, if you will, and there's a lot of feeling that we had voted on this once and didn't appreciate the federal government getting involved, and therefore we sent a strong message back that we supported medical aid in dying. The 23 years of data that we've gathered through the Oregon Health Authority is that 2,454 people have died as a result of ingesting the prescription. It's important to note that more people actually receive the prescription than actually take it. Last year's suggested that 66% of the people who had a prescription ingested it and died as a result of that. But more people receive it and more people want to talk about it than actually follow through with that. Since our first legalization, it took another 10 years before a second state legalized medical aid in dying, and that was the state of Washington. But since that time, 10 states and the District of Columbia have legalized medical aid in dying, and all have patterned their requirements after Oregon's law. There are a few things that I think are important to take note of. And one was that the early assumptions were that medical aid in dying would be heavily influenced by insurance companies, because at that time in the 90s, Oregon was a very heavily managed care market. But thankfully, there's no evidence to suggest that any of these decisions have been influenced by insurance companies. There's also fear that that somehow this law would target people who are disabled, and there's no evidence to support that. And also the fear was that there would be a flood of people moving to Oregon to avail themselves of this. And we certainly know that the very high profile person who's moved to Oregon was Brittany Maynard, who moved to Oregon to avail herself of medical aid in dying prior to California legalizing their version of the law. But the other thing to know is that in the 23 years that we've been gathering data, every single year the data supports 3 reasons to pursue medical aid in dying. And the one is 91% say that it's the desire to pursue this is because of losing autonomy. Another 90% is the less able to engage in activities that make life enjoyable. Also, the third one is loss of dignity. And that has remained true in all of these years that we've been gathering data. Much farther down the list are the burden on family and caregivers, inadequate pain control, or financial concerns. And so in the early years, I think there was an assumption that we must not be treating pain and symptoms adequately. And yet what's important to know about Oregon is that we historically have had very heavy hospice penetration, as well as access to palliative care, despite being a very rural state. And most years, approximately 90% of patients who avail themselves of medical aid in dying are actually enrolled in hospice. And so it suggests that the decision to pursue medical aid in dying is heavily influenced by culture and personality. And it also suggests that it's not related so much to symptom management, but rather a desire to control the manner and the timing of one's own death. We also know that what the 3 areas that are continually come up in conversation are the fact that, again, having a prognosis of 6 months or less is not always easy to establish, as Dr. Comfort measured, particularly for people with dementia who are not eligible to avail themselves of medical aid in dying because of the lack of capacity. Another group of people who have talked a lot about medical aid in dying and the problem with prognosis are people with ALS. And because it requires the ability for a person to swallow or self-administer the lethal medication, it's often difficult to predict when one will lose a swallowing response. And a number of folks that, again, are concerned about the restrictiveness of medical aid in dying are senior citizens. I've talked to a lot of groups who really want a provision for people to be able to avail themselves of medical aid in dying if they develop dementia. And yet, again, they at this point are not eligible as the law is written. A few lessons learned, and I forgot to set my timer, Dr. Comfort, so I'm sorry if I'm going over my 7 to 10 minutes. I think a recent study that on medical aid in dying suggests that it may have unintentionally made it more difficult for patients with less education, from more marginalized backgrounds and non-cancer diagnoses, as I mentioned. And because the logistics of obtaining the prescription, getting two physicians to determine your 6-month or less prognosis, finding a dispensing pharmacy is particularly difficult in rural communities in the state of Oregon. The other thing is that one has to pay out of pocket for the prescription, which is a little less expensive now that we're using a compounded formula rather than Seconal or phenobarbital. But I think it's also really, really important to acknowledge that the lessons learned in Oregon may not be easily translated to states that are more diverse, who have very different populations than we have here. We are, while Oregonians are proud to say that we're very spiritual, we're the least churched state in the nation. And there are those who suggest that medical aid and dying passed here because of that as well. So I think it's important, and I would just say in conclusion, that it continues to be very controversial and is not more widely accepted in certain regions of the United States, and is heavily influenced by culture, personality, and potentially religious status. The debate can and should continue to be taken seriously from medical, legal, and ethical points of view. And I think much more study is needed to elucidate patient preferences, systemic bias, and overall trends. And I think I'll stop with that.
Thank you so much. Excellent, Susan. So I think we're going to roll into our last presenter. I think I see a theme here. We've gone from policy to the implications of policy. We're now talking much more about the personal experience of the individual. And so I think Linda Golding is a perfect person to take us through her experience working with patients day to day over at Presbyterian, and really getting an idea here about how any of these issues roll into the personal experience of patients and the personal ethical considerations that we have to come and start to face when we move from our theoretical into the practical. So Linda, guide us on.
Great. Thank you so much. It's really, as the world is on fire, it's really an honor and humbling to be together here to talk about something so meaningful, despite the fact that all these other things are going on around us and that we can't control. And we sometimes think that we can control how our lives end, right? So that's kind of what we're talking about today. So I'm gonna invite us all just to take a breath, right? Because we've heard a lot of stuff. We've heard a lot of ideas, a lot of facts, a lot about business, right? And I just want to pause, and actually I'm going to invite you to release the breath that perhaps you've been holding, since we hold our breath most of the time, and just come back to a regular breath and talk about who we are. So a few observations. So as a chaplain, and I'll tell you honestly, I'm a second career chaplain, which means I had a whole life before I got into this line of work of spiritual support. As a chaplain, I feel really strongly that my work is to help people remember who they are when they're not in a crisis. That's any kind of crisis. Now, I work in an acute care hospital, okay? So that crisis affects patients, that crisis affects their families whose lives have been turned upside down. Patients who are not feeling well, of course, but have also had some of their identity stripped away, because that's what we do. And staff and students, right? Because we come in, we put our tags on, and we become a little different too, right? Because we're walking into a system and we're part of that system. And I'm actually really glad to be in the system that I'm in, but I am always having to remember that there's different roles for each of us. Okay, so what does the chaplain do? So the chaplain's work is to help people recapture what's important to them, identify their values, identify the people in their lives that are important to them, identify what dying well means. And I pause on well because what well means for me is going to be different for every single other person. And by the way, we're all going to die. We're all going to need the services that all of you have spoken so beautifully and eloquently and passionately about. So there's a barrier that we face as soon as we walk into a patient's room who has some understanding and whose family has some understanding of the fact that death is approaching a little more quickly than they thought. Once upon a time, a long time ago, the people who looked after our bodies and the people who looked after our spirits, which I'll talk a little bit about defining that, they were the same person. Over time, that began to take different forms and people began to specialize. And one of the things that I find really remarkable in my experience in palliative care work, which I do as an adjunct to my regular clinical work, which is largely in neurology, is that there is a rapprochement, a bringing back together, actually, of people who are caring for body and spirit in the same person. And I really admire that, and I really respect that. So I stick to my lane, but I acknowledge that all of that integration is really meaningful. And so perhaps there is a turn that we can notice, a turn that we can begin to embrace, right? In how some people and some systems are able to allow for this both and. So a word on spirit. So, chaplains are mostly thought to be religious critters. And I like to look at us as more providing spiritual support, depending on what you need today, which might be different tomorrow, right? So some of you who are on this call have heard me talk about this a lot. So I think of spirituality as that which gives you individually your greatest experience of being human today, which will change this afternoon, this evening, tomorrow, who knows, right? So my job is to help you recapture that and to help the medical institution that is surrounding you as patient, as family, as staff person, support that, right? Sometimes it's easier than other times. I wanted to also raise this idea on the ethical part of things. That really my main interaction with the ethical issues as a chaplain in an acute care hospital are about autonomy. And my main concern is whose autonomy are we actually talking about? Who is making the decisions? Sure. What are those decisions representing? Yes. But who's the one who's saying this isn't working, right? A lot of calls come in to chaplaincy. The patient is in denial. The family's in denial. And, in the back of my mind, I think, well, yeah, wouldn't we all be? But the reality is we haven't asked what that means, right? So I ask the docs, they say, oh, they're looking for a miracle. I ask what that miracle is. The response usually is, I don't know, that's the chaplain's job. I trot upstairs. I ask what the miracle is. I want to see my dad's eyes again before he dies. I want to not be in pain when I die. Right? So we're talking about trying to bring these things together, trying to bring the humanity into, maybe not into, back into all of this medical stuff that is remarkable and incredible. Every day I am astonished by what's possible and what my medical colleagues think about and what they are able to do. So we want to bring the person into all of this. Sometimes the chaplain is the voice of the person in the room or helps the voice be heard in what can otherwise sometimes feel a little like a business meeting. about the process of illness. I want to tell you a very short example. I had a patient some time ago who was a palliative care doctor in another state. Came here to New York for care, clearly learned quickly that there was not going to be a future of curing the particular set of concerns and illnesses. And the doctor said, and his family, who were well aware of his work, said, I think it's time for palliative care. I do not want any of these interventions. Fine. He was put into a palliative care situation. He began to decompensate. His family was around him. We had some really remarkable conversations. And the day that he died, he said to me, I am ready to die, but I don't know how. And I thought, this is a remarkable moment, right? This is incredible. And we had a conversation, which his family witnessed, about how have you helped others die? So an opportunity to help him remember some of his values, some of what he practiced. And I had no idea about the impact on that until I saw his family crying. And then I thought, well, I have two choices. Either this was a terrible thing to say, or this was a door that opened. He died a couple of hours later. And what I heard from the family in terms of their response was that this had actually been a very powerful moment for them to remember the fullness of who this man was, right? In addition to dad, in addition to the farmer, right? All of the parts of him came together. So I leave that with you, going back to the mountains and the river, right? The watershed that we started with Lauren, the watershed of, oh my gosh, it's a palliative care doc who's going into palliative care. Yikes, this will either be really hard or really easy. We don't know what it is. But the river that he was on was still his own river, his own path. And the memory, the recollection, the integration of the full who he has been was actually what took him perhaps across the sticks. So thank you for this really remarkable opportunity.
Linda, thank you. Oh, I think this kind of takes us to our branch point here, which is now, instead of the talking heads talking, give us the opportunity in terms of this. So I think I saw some hands raised there, and we've got to decide, do we hustle on to our sessions, or can we take a couple of questions if people have them?
I think
David?
you have a few minutes. Take some questions for a few minutes if you
So
can.
David, I saw you with a hand raised there. Was that a mistake, or was that actually a question? Oops, we've got you on mute. And let me see if I.
He cannot unmute at this
Uh-oh.
time for this
No, actually,
session.
Oh,
So,
look at that.
Actually, I could.
Look at
oh,
that.
great.
And Christopher, that was not a hand raise, that was applause for Linda.
Ah,
Calm
excellent.
voice, I always find soothing.
Yes. Excellent, excellent. So I think, Anne, I'm going to turn it over to you in terms of the breakouts to give us some instruction on where.
Education, social work education, nursing education can be more inclusive of the historical experiences of our patients, and contextualizing the fact that patients, as we discuss medical aid in dying, that until we resolve or reconcile some of the atrocities that have occurred in U.S. healthcare system, how then can we begin to have effective and meaningful conversations about medical aid in dying when people haven't lived lives in ways that were inclusive and equitable? So that was one part of the discussion. It was very rich. There was also a discussion about tools and strategies. For example, the AMA and other organizations that have put out statements about inclusivity and ways that we can assist patients that have been historically excluded and marginalized. There was discussion about implementing things like talking points and creating platforms and tools for clinicians and policymakers so that there's a repository, if you will, of information that people can draw upon or draw from, because there are gaps in education and knowledge about the historical experiences of populations that are also underutilizing this resource, if we want to think, or this option of medical aid in dying. So how do we close the gaps? How do we become more inclusive in not only the conversations, but the actual structural ways and behavioral action-oriented ways in which we are engaging or not engaging specific populations? And I think I saw Cara comment that she was not able to unmute. So perhaps Cara would like to add something as a bioethicist.
Oh, yay, I can unmute now. No, well, I think you kind of covered it. I kind of was trying to do it and you've covered all the points, but I just wanted to say thank you again for not only your work, but the conversation and just the discussion and how we really just need to really uphold making it happen as opposed to waiting for it to happen at this time. Thank you.
There seemed to be a general sentiment within our group. We acknowledged we were speaking to the choir. People didn't have to participate in this session. They chose to participate. And so there was this narrative of preaching to the choir, but what more can we do to get people in the spaces who run away from these types of discussions? And I say run away. Someone commented about when they have such grand rounds or trainings, people turn off their cameras, they disengage, they said we've had enough of, those kinds of things. And what, if anything, can be done to help our colleagues who are disinterested in this topic to realize that they might be doing harm to our patients and families by not having a baseline level of knowledge and education and understanding about diverse patient populations?
So David Hoffman reminds us that we can raise our hands by going to the bottom of the toolbar, and we'll be able to see it. And Rich Siegel has figured that out, and help us out here, Rich.
Thank you. First of all, I also want to say what Karen talked and led the group was awesome, and it's a wonderful to continue the learning experience on how to do this more humbly and better, so to speak. But I did want to add one other thing that even though this is about medical aid in dying, if we truly want to respect where people are at, I think there's and I said this in a small group, there's too much of a push to make people accept palliative care, to make people accept the DNR. And what we need to be also doing, if we're truly going to be where people are, is if some people want to go out with guns blazing, we need to support them in that. And we need to help our staff who are telling us that they have moral distress about it to say, get over it, because it's not about you, it's about this people, the patient and your family at this moment. So thank you.
Yeah, Dean wanted to know whether or not this group actually talked about mental illness in a variety of different severities and inequities or access to care or other issues such as that, or did you keep it to the typical medical issues in your discussion?
We spoke primarily about the medical issues, caring for patients, access to families. How can we hear more from the patients and families and communities whom we're caring for to make sure that their voices are included in these discussions? And so we really centered on direct patient care, policies, and education.
Okay. Other people have specific experience or examples of these inequities or this misunderstanding of individuals or communities based on difference. I actually have one. when I was in med school, it was a long time ago, we were all had to do community-based projects for education. And so we decided to do an education on contraception to teenagers in the city of St. Louis. And it was a mixed group, but predominantly Black teenage population we were talking to. We did three, I thought, excellent presentations. We were young then. And lo and behold, we got called into the dean's office because they received a letter from some of the elders of the Black community in St. Louis saying, how dare we go and talk about contraception to the community because of the perceptions of influencing or presenting a very white understanding of rights and reproduction rather than, and what later came out was that there was a certain feeling in the community that there was, this was an example of, and we were the medical community coming in and trying to control and limit reproductive rights for the population. And I was shocked, but then on reflection, understanding what the history, at least at that time, had been of the Black community in terms of access to medical care, it became much easier to understand the idea of people coming out with the imposition of an expertise rather than an inviting of the community into a discussion of things. So it was a lesson very well learned, and I think an example of the differences in the perceptions of community in terms of medical care.
Dr. Comfort, if I may add a comment, I think when someone hears a comment like the example that you gave, being in a Jesuit institution, I think that response isn't necessarily racially bound. There could be a host of cultural reasons why someone may have an aversion to contraception or this idea of, reproductive health, et cetera. But if we were to sort of couch it in Black people's experiences, I think we only need to look as far as the eugenics study, which was a study that continued until well into the 70s, in which Black women were sterilized without their consent and without their knowledge. And so when people are reacting and responding to different types of educational information that's coming from a non-trusting space like the US healthcare system, automatically people's mind go to what has happened to our people in very recent times. And so many people are not even familiar with the eugenics study. So we need to look at what has happened to Black women in terms of reproductive rights and sterilization and the atrocities. So I'll just stop there.
Absolutely. Other comments? Okay, I'm going to move us on to topic 2. So this is the second group. This was the medicalization of dying. I have to tell you, N. Michael Murphy, who ran the Albany Hospice in the 60s, really in its infancy, left Albany and went over to Europe and does most of the training for medical aid in dying for the palliative care people in the Netherlands and throughout Europe. And as he was getting on the plane, he indicated, I hate this medicalization of hospice. So this is sentiment that has existed in some of the basic caregivers within the movement, but this is now the medicalization of dying. And lead us on in terms of any comments, group 2, related to that.
I can kick us off. Linda and I were both, and Anne as well, we're both, all three of us were in that group. And I think, Linda, correct me if I'm wrong. I think a lot of our group members were clinicians, or at least the vocal members of the group. And so there was, I think, a focus on thinking about how to deal with some of the incentives that exist within the hospital structure for sort of the conveyor belt of sort of medicalization, where there's lots of, I think the phrase I use was, there's lots of protocols to increase the intensity of care and very few protocols for how to back off. And so when people are, and one provider, one clinician pointed out that she was very concerned about one of her geriatric patients who was just admitted and trying to get that patient out. What was the phrase that she used, Linda? Turning the aircraft carrier around. Yeah, so once a patient's admitted, it's really hard to get them back out again.
Right, and discussing the issues of harm, right? Potential harm in a place that's actually supposed to provide care, right? And that sense of like how uncomfortable that is.
Yeah. One of the things that that I think a lot of folks were thinking about is, you know, well, what do we do with this? If this is the system we have, right? We have very high levels of medicalization at the end of life. How can we sort of ratchet some of this back, really focus on reducing care and also center patient preferences? And I think we all mentioned a couple kinds of different levels. And so there's, you know, I think most of us agree that we don't have much control over the structure of Medicare or the structure of you know, Medicaid. But there are state laws that we might have influences over, but there's also institutional protocols, institutional and culture, you know, sort of internal hospital culture. There's ways to reform those kinds of institutions, including pause points. I mentioned Jessica Zitter has a nice book called Extreme Measures, where she talks about some institutional reforms for demedicalization. But then I think the thing that we ended on was this question of individual and cultural, the question of how do we educate a population that no longer sees death as a normal part of human life, because we don't see it anymore. It's kept hidden away from people. And so how do we demystify it? How do we, you know, have it come back as a sort of normal part of human existence, as opposed to this thing that we fear at all costs?
Right, to be avoided at all costs. Yeah, exactly. Was there anybody who was in the group who wants to add anything to that? That's a great summary of where we were at.
Yeah.
Could I just make a comment? So I wonder if people, it's rather not so much denying death, but later, because of these advances in science that seems to make later possible. So again, that's sort of how you have, I think that the focus on education is how you have those conversations with patients over time. So that there's based on values and choices, because with choices, people are going to, you know, because life has great value often. If you're going to lose it, if you've been living longer, people want to live a little bit longer. So it's not necessarily denying of death, but just putting it off a bit if you possibly can. So
absolutely. I think that's right. And I think to try to deal with language, I think is where we got to, right? So if the medicalization is one language, what are the more humanistic languages, bits of language that can be put into that or mixed into that, and to make some shifts there? I think, Anne, you had your hand up.
Yeah, I just wanted to add that I think kind of what stumped our group is just that it's really hard to change public opinion on the dying process. And, you know, to Nessa's point, I think people maybe just think they can interfere with and stop the dying process. And if they had a better understanding of just, you know, what the costs are of extending that, I mean, the costs in sort of human comfort, that things like resuscitation can be very painful or have whatever. I think it's really hard to influence culture. And some of the doctors in our group, I thought quite rightly, kind of said it's not just them, because they're talking to families and what families want and what people want. And so people maybe, you know, it's hard to know all the influences and cultural influences that shape what people think they want at the end of life.
Yeah.
Randy.
Thank you. Yeah, I think that those of us who are providing healthcare need to take some accountability here, because I think that we're trained to believe that death is optional and that death is a personal failure as a physician. And so the degree to which we have influence on that public opinion, and you know, I can remember fighting with doctors who were trying to get their dying patients into the ICU, and that the I have seen families fight with their oncologists in particular to have, more and more and more done. So I think when you're talking about education, I think we need to not only focus on the public, but on the healthcare professionals, because a lot of us think death is optional and take it as a personal failure. And not to preempt our team a bit, but it was very striking to me that the opening discussion for us on medical aid in dying is, how do you deal with the apparent discrepancy as a medical professional when you're trained to make people better, and then you're going to help them die? And what does that mean to make them better? And if someone with a terminal disease who is ready, making them better might mean not torturing them on machines for an extended period of time, and whose value is it and who defines that? So I think there's a lot of education to be done in the healthcare profession.
Yeah.
I'll just add one quick thing that we discussed in our group, which is that there's trade-offs to having a specialization of palliative care, which is that it at least according to one palliative care physician that I interviewed a while back, which is that it kind of gives other physicians the permission to not do the kind of work that palliative care physicians specialize in. So having hard conversations with families and having hard conversations with patients. And so there's this kind of trade-off. Palliative care is a wonderful specialization, but all doctors should be having conversations with their patients about goals of care. And all doctors should be talking to, families and patients about what the likely outcomes of a certain treatment are. And a lot of times we aren't doing that. And that has to do with all sorts of other incentives and various kinds of structures. So.
Yeah, I think Sean Morrison has addressed that in a unique way, in that although he's a specialist in palliative care, he's a believer that palliation is the bedrock or the foundation of medical care. And you move on to curative care after you've figured out how you palliate. And whether that's asthma and you make people breathe a little bit better, it doesn't cure the progression of the asthma, but it sure makes you feel a lot better. That's palliative. I'm fascinated by how little we understand of the basics of something like, let's take DNR. What do you think the success rate of resuscitation is in New York City if I drop right at my desk here? I'm in a hospital even. What do you think the success rate of resuscitation is? Well, now we teach EMS. Every EMS person from the fire department has to come to be educated by us in palliative care. And I thought that was crazy. What am I educating acute responders that end up whisking people off to the hospital so they can get to the ICU and survive? But if you look at survival statistics for a on-call to a outside of a hospital setting in New York City, the success rate of resuscitation is 1.8%. And that success rate is based on survival to 2 weeks, and it does not take into account the functionality of the individual based on the resuscitative effort. If you look at a hospital setting, it's 50% in the CCU, because they're all young men who've just had their heart attack. It drops down to about 15% in ICUs because it's chronic disease, typically surgical complications. And if you move to a med surg floor, it's less than 5%. If you move to a unit that is just doing community-based work, it's less than 1%. However, if you watch House, it's a 98% survival rate. So I think one of the things that we have done is we've turned what is really magical thinking into thinking that there is clinical significance to it, and not been able to ferret out what is just magical thinking and stories that we tell patients and their families as we try to educate them about the benefit of resuscitation. And I don't think we've been doing a very good job of that at all.
Hey, I mean, I read an article where it said most people learn everything that they know about medicine from that doctor show with George Clooney. I forget the name of it. So like we should be involved in making those stories, right? They learn about things like transplantation and resuscitation in there. I always wonder, who are they getting as consultants to write these stories? It's so disappointing. And then they had that, there was a show on transplants somewhere in another country, and they gave a different narrative, and they had thousands of people sign up to be organ donors. It was a game show. It's like, who gets to get the organ? Literally a game show, and people signed up because they saw a different approach to it. But I want, somebody mentioned Jessica Zitter's book, and I just wanted to say that, like, what moved her to go from critical care medicine to palliative care was what you were just describing, and that everybody in the room resuscitating a patient, everyone in the room who was doing it knew that they were doing something futile, and how horrified she was at that experience, and how mistaken she was, and how she couldn't, the ribs were crushing under her hands. It's just such a powerful description, but it's really true. Everyone does know. The likelihood of you get that, I didn't know, was that 1.8%, which is, I was going to say something much higher than that.
Well, it's interesting that New York's 1.8%. In Seattle, did you know that it's 35%?
I was going to say 25.
Yeah, and they actually published this in the Journal of Cardiology, and an editorial for that actually said it's because they're healthier. It's Seattle. They're all outdoors people. It's a small city. They get there faster. And the emergency medical community from Seattle wrote in response to the editorial, and they said, no, that's not why it is. We don't resuscitate people with the rhythm of asystole because they're dead and it doesn't work. So we don't put asystole in our statistics. If you put the asystole workups in the statistics of New York City, the resuscitation success rate, if you take it out, goes to about 35%.
But we really think at that, don't we? At like making decisions, like now that we can do transplant, everybody gets one. It doesn't, why can't we be better at making good decisions about, who gets?
Well, I think these stories are important to tell because I think they focus us on what's reality and what is magical, and helps us to make our decisions, I think, a lot better. I'm going to move us on in a little bit because, John, you led a group which was all about financing and public policy. I'm sure it was riveting for the group. So lead us off, and then anybody who had comments about this, please join in.
I think it actually was pretty riveting, if only going by the clip of our discussion, because once we got rolling, really didn't have much of a lull until we were all warped back into reality here. I guess I'll just try to summarize a few of the high points that I took from our discussion, and then open the floor up to everyone. That we did, I think, speak briefly about the idea of medical aid in dying, and built on some of the topics that I had mentioned in my initial talk around the idea of making it potentially be covered under insurance, or what the state could do to intervene in the realm of provider education. But we shifted, I think, very quickly to this idea that any training, whether it's the state sponsoring it or coordinating the sharing of ideas, whether it's systems or third parties creating it, that it needs to hit a few key points. And probably the first one is that it needs to be accessible and interdisciplinary, because, we all know this, we're extremely busy as a healthcare industry. There's never enough hours in the day. And we work in a model that is extremely varied. And the person who's going to connect the dots for a patient could be the chaplain, could be the social worker, could be the PA, could be the person who just happens to see them at check-in. So making sure that whatever training is available reaches all of those people in a way that's useful is what's going to move the quality needle forward. Beyond that, though, we talked broadly about the word culture, and for us, I think that moved beyond perhaps the social studies idea of culture to this idea that that culture almost becomes this little microcosm of the person. What are you afraid of? What does control over your situation look like to you? How would you prefer to see things proceed? So it's more than just some of the immediate or the general, but it really does focus down truly to the individual and how do they think, feel, perceive with respect to the situation. And having those conversations is not new. We all, I think, are used to doing that with patients, but it, I think, remains a difficulty that is compounded by the crisis, if you will, that is the end of life. So I think the other big piece we talked about with training was having that awareness, understanding the patient's condition as it impacts their ability to express those things, the consistency with which we have these conversations and these practices, but also focusing on, are we collecting data on why and what, why did we do the training? What did that teach us? What did that do for a patient? So it was, I think, a rather broad discussion of not just how do we pay for a training, because we all, I think, sort of know ways we could do it. But what does the resource look like? What does it look like within this realm? And I guess with that, I can already see a few people in my group have unmuted or at least moved and showed signs of life to their camera. So I'll open it up, I guess, to others who want to share a comment. David.
Thank you. Yeah, thank you, John. What was most interesting about our group, I think, is what we didn't spend much time talking about. And specifically in that regard, there was no articulated need for state funding because there are so many better ways of providing training. And the other thing that wasn't talked about much was specifically training about MAID, because we immediately, and this is thanks to John's leadership, moved to the discussion of training regarding the entire continuum of care, from palliative care to hospice care to end-of-life care to ending life care as only a little piece of that continuum. And the notion, which I advanced, that the medical aid and dying bill, when it passes, will be a catalyst for discussions about training, but the training has to be about so much more than medical aid and dying. It has to be about the continuum of care. It has to be about cultural competence. It has to be about systemic racism and implicit bias. And I know my volunteer organization, the Completed Life Initiative, is ready and anxious to step into the breach and facilitate all of that training, culminating, by the way, in what is the most effective training tool. My students in this group will giggle when I say this: role play activities, right? It's all well and good to do these Zoom calls, but then breaking out into pairs where people actually practice the skills with another human being, that's how you get adherence.
David, if I could interject real quickly, when between the 3 years when the 2 ballot initiatives were passed on medical aid and dying, the press just was saturated with information about advanced care planning, palliative care, hospice, all of the alternatives beyond medical aid and dying, which I think really helped elevate end-of-life issues. And then the second very hopeful thing I'd like to throw in is that in our School of Medicine, I teach a class for first-year medical students on living with serious illnesses. And the best part of the class is we recruit a bunch of patients, and each student has to follow the patient for 2 months. And they're scared. And I, to this day, get stopped in the hall by former students who say that was the best class I ever took. It taught me to be less afraid. And then we are one of the first medical schools that, as part of the requirement for graduation, all of our students have to be partnered with in the sim lab with professional actors. and they are graded on their ability to have these difficult conversations and giving bad news. And if they don't pass, they get sent to sent to reform with people like me.
That's great, Susan.
So there's nothing more valuable than that kind of face-to-face, hands-on type of experience. Having said that, I was making this point in that group toward the end about how the Empire State Bioethics Consortium might be uniquely situated to create some kind of multidisciplinary materials for as part of a training program. And it could cover the clinical, the social work, the cultural, the legal and other aspects of it. I've made that case before in connection with training for ethics committees, but it also has a role here that we should keep in mind. It's also would be a really valuable accomplishment for this organization. While I was making that point early on in it, it got cut off and sent to this big group. I thought maybe it was being censored, but that was an idea that to consider out there.
So I know one of the concepts Mary Beth has brought up is the idea of a generalist palliative care versus the specialist. So it's interesting, we talked about a lot of things, but one of the things that has not come up yet in anything I've heard is this idea of the expectation of a generalist approach to palliative care so that it does not become the domain of a specialist, but it's embedded into what is done in care of patients by every practitioner. Mary Beth, you have comments on that at all?
Absolutely, Chris. Thank you. We have worked for a number of years now, and Chris is part of our program on a generalist level palliative care education program that is funded by our area aging agency in Westchester County under the leadership of Commissioner May Carpenter, as well as a HRSA grant from the University of Rochester Medical Center, Finger Lakes Geriatric Education Center. And the model that we've used is very much along the lines of what you folks are describing and what we discussed in our breakout room, interdisciplinary, also inviting people to participate from the services world, including aging services, health services. And one thing that perhaps we have not spent a lot of time on explicitly is the very important role of social work. I know, Karen, of course, we're delighted to have you here today. I think you're a model for us in terms of what social work can do in this kind of education and training. But I do think we need to encourage a bigger role for social work as we move forward with education and training for the whole continuum of care. Thanks, Chris.
Very good.
Thanks for the shout out to social work.
Now I'm going to move us on a little bit and ask my talented group of people that were with me to comment upon what was discussed in the home care and hospice barriers to access issues. And Dean, you had comments. Let us know.
You were saying something at the end of your talk. What was it?
So we were talking about non-abandonment and the strange strategy that we have in end-of-life care to refer patients from established care systems into the unknown. Having those organizations have to establish intimate relations with them overnight, whether it's hospice, palliative care. So somewhat of an enigma that my institution, which has a core value of non-abandonment, essentially has patients abandoned by care systems every day with their admission process as we go through the process of having to create that relationship. And I'm not commenting on that as a bad thing. I'm merely pointing it out that that's the process. That's the system we have. Fascinating to see that's how people get into these care systems by essentially abandoning the care systems they have.
Because they use the phrase a right to die, and we understand it in bioethics, but everybody dies. There's no right there. You just want the right to die comfortably, as I see it. And ours had to do with home care. And to me, that's the best place to start the dying process. And the hospice and palliative care have their role, but home care is unaffordable and a big mishmash for the caregivers, especially the unpaid ones that are giving up work, or they're elderly and they're not doing their exercise because they're caring for others at home. So it's beautiful home care, because I think that was the topic, but yet it's fraught with peril because of the fiscal design of the medical system. It's what I call serpiginous. It's, yeah, we're not treating the end of life issue properly.
And Richard, you're right. We began our conversations by realizing that to enter into these systems that we call end of life care, you have to have an extremely stable situation at home. You have to have caregivers. Those who are fortunate enough to be dually eligible are easy to fit into those systems without too much problem at all. But for those who do not have a Medicaid benefit and a very, very rich Medicaid benefit here in New York, for the support of a home stay, really are a challenge for both hospices and palliative care services, because those services are custodial services in their foundation. And unless we solve the problem of how do we provide foundational support for the elderly to maintain them at home, it's a problem. We also went over the issue of warehousing of elderly individuals related to particularly the diagnosis of dementia, and we compared that to how patients with disability are cared for. True, not dying, but certainly very, very dependent upon both the medical and the support structure. And if you have a dementia, you end up in a nursing home with multiple patients in difficult housing. But if you're fortunate enough to have eligibility for Medicaid and you are disabled, you will end up in a group home with a limited number of people being cared for with you, and real attention to both caregivers and staffing for caregivers, even though those of us who have experienced that system would say it's not well staffed, but it's certainly better than nursing homes, and with real attention to maintaining the autonomy, independence, quality of life of those that they care for. So we talked a little bit about the idea of, does the model that we're using for the care of elderly, whether it's end of life or it is with significant illness, really promote the idea of a palliative environment? And is it in fact beneficial to them, or do we need to rewrite the book about the process we use for the environment for where we care for people with serious illness? And then I'm going to quickly move us on, because this was promoted as a conference on MAID, wasn't it? So here we are in our last section, and this is medical aid in dying and considerations for the reflective practitioner doing their work. Susan, lead us off, and then anybody in the group, please chime in. It's very important.
Thank you, Dr. Comfort. I would love for the group to unmute themselves and add their very rich perspectives and some of the themes that I jotted down, but I'd like the others to speak as well. Was we talked about autonomy versus care. We talked about better is, I love this quote from Randy, better is relative and contextual, because we were talking a little bit about the struggle to embrace this idea of medical aid in dying if our goal as practitioners is to relieve suffering. And of course, it led to a discussion about how subjective suffering actually is, and that we may be providing the best care that we possibly can, and yet it may not relieve existential suffering that some of our patients tell us about. And also, we talked a little bit about the concern for litigation, which I think is perhaps more prevalent in New York than it might be in my state. But I'd welcome input from others who were in this particular session.
Yeah, Susan, one thing I think that we talked about that was very important to me to remember, and that is a discussion about you gave the statistic of the time between getting a prescription and actually taking the prescription and the percentage of folks who do and don't, and just to remember that the education that we give about options should include all the options, and that sometimes someone might think that they want this and we may advocate for them because that's sort of our point of view, but it may be that other options would be more helpful to them and that they would prefer that. And so just to remember that in the process, I think that was an important point that the group was talking about.
Thank you, Randy.
Janine.
Yes, we also talked about the top 3 reasons for medical aid in dying in Oregon, and a little bit more about loss of personal autonomy and the inability to engage in activities that people find enjoyable. Also talked a little bit about having conscientious objective for physicians, pharmacists, nurses, social workers, when it came to having a discussion about medical aid in dying. So it was truly a helpful discussion and learned a lot. We also talked a little bit about our personal struggle with the whole concept and how to move through that. Thank you.
Thanks, Janine. Others in our group that would like to add your perspectives?
Nessa, I see your hand
Yeah,
raised.
I just had a question for the group. Did it come up about the whole issue of abandonment, that the nurse who has a close relationship with the patient must remove him or herself from the setting? So at the time, again, of this extraordinary act, in a way, or decision, that's been, it's been the patient's decision is being supported by the staff because of patient autonomy, but yet the staff have to remove themselves. So is this a double message?
So with medical aid in dying, the conscientious objection component has to do with if medical aid in dying, not unlike abortion, stands in contrast to one's personal sense of ethics. They have that option, but the issue of non-abandonment is written into that in the sense that the person must, in fact, make sure that the care is handed off to another clinician. Now, what I would say about that is that when it comes right down to it, what I've seen a number of people do is stay involved, even though in concept they didn't love medical aid in dying. So that is one of the areas. The other thing is that—
Can I just follow up on that? So,
oh yes, please.
Yeah, so it wasn't that it was that the involved practitioner who's been caring for that patient and family was not allowed to be by the bedside with the patient at the moment that they ingest the medication. Is that correct or not?
That is not correct. People have the choice.
Those can be that.
Yes.
Okay.
Yes. It almost never, however, happens in a hospital. It is almost always in a home setting.
Okay. But the nurse can be there.
The nurse can be there. The physician can choose to be there. The social workers, yeah.
Awesome. Thank you.
The only place where that is prohibited is in our Catholic health system here in Portland, and their employees are not allowed to participate. But that is not true in our other health systems.
Yeah, Nessa, the incident you're referring to occurred in California. The nurse involved was Thalia DeWolf, and she actually got the first annual Faith Summerfield Award for Courage in long-term end-of-life care for her willingness to come to the aid of a patient who experienced aspiration as she was ingesting her medical aid in dying drugs.
Wow.
Happy to talk about that some more.
So one last thing, Susan, I was asked a very interesting question that I actually had no answer for. And I'm interested in your perspective on it. Is a movement to medical aid in dying an indictment of the success of palliation? that we offer families and patients on a consistent basis. And I heard that and I absolutely didn't know what to answer.
So can you repeat that? I want to make sure I'm hearing it correctly.
So is the introduction of medical aid in dying universally available, essentially a substitute for a system that can't provide adequate palliation for patients?
I definitely think it's not a substitution for palliative care. And I would say, I think one of the things we've learned in our experience is, again, most of our patients who do choose medical aid in dying are on hospice. It's greater than 90%. And so I think there is this small but determined number of patients who will continue to pursue medical aid in dying, regardless of the most heroic efforts on the part of both palliative and hospice teams. I would also say in our breakout session, I mentioned that providers rarely offer medical aid in dying. We all wait until the patient brings it up. And that's actually been challenged by some groups of people who were withholding information about a legal option. But I think we were, especially in the early days, so concerned about not in any way being perceived as promoting that for patients or pushing the decision about that.
And I think you're echoing some conversations from Susan Cohen, who really was concerned about advocacy coming from providers because of the influence the opinion has from a provider, and the idea that personal bias related to decision making certainly certainly some problems in terms of patient decision making.
Yeah.
Well, this has been a fascinating journey today. I think wonderful discussions, and we appreciate all of your input and hope that we made this just not a talking session for talking heads, but actually provided the opportunity for some insightful thoughts, stimulating ideas, and good conversation related to them. I have to thank Lauren Hall, who I think was spectacular. John, thank you again because of your expertise that is essential to us understanding the policy and politics as well as the economics that have to do with all this. Linda, wonderful, soothing, insightful. Thank you. Karen, I think you have touched upon topics that the medical industry has yet to really understand and address. And I think the next 10 years is going to be all about the idea of, rather than just our typical comments about cultural sensitivity and the idea of understanding other ways of being, but will be fundamental to how we provide care going forward. And then lastly, Susan, thanks for coming. Great insights. Hopefully it has helped us here in New York to understand the experience that's existed 3,000 miles away across the country. And may it be that we can learn from some wisdom as New York goes through the decision of first deciding about medical aid in dying, and then secondly, the difficult task of what implementation of aid in dying would look like if approved, and specifically, what's the education related to this all about, because of the difficulties we have in the completeness of our understanding so far. So unless something else, I wish you a good day.
Thank you so much.